Hello there, everyone, ladies and gentlemen. I've got Dr. Mark Craig here. So, firstly, I'd like to say thank you very much, Mark, for coming along and doing this little presentation. We would have loved to have had you in person for our audience tonight, but unfortunately, your busy schedule has taken you elsewhere. So, I had the idea to just sit down with you and have a little bit of a talk about your experience in your clinical experience and vast experience managing spinal disorders and back pain. So this is really just a casual talk about your experience with back pain and how we've integrated our practices, in particular with functional movement therapy, and just so that our audience tonight can see how we work as a team to manage this very challenging problem of back pain in our community. So, Mark, why don't you tell us a little bit about yourself and your practice as a back specialist?
Thanks, David, and thanks very much for inviting me. My background is that I was initially a country GP, and when I came back to Brisbane 20 years ago, I went into the private emergency departments, and while I was there working in that arena, I saw a lot of people with back pain and sporting injuries, motor vehicle accidents, workplace injuries, and I was struck by how often people are frustrated by the system that they find themselves in, where they don't get results for back pain. And I decided, because of that, I decided to study and do a master's degree in musculoskeletal medicine, and I've been working full-time in that field for the last almost 20 years. What I've observed during that time is confirmation of my initial impressions that people find the system very frustrating. They find it difficult to find practitioners who are confident and competent at managing their back pain. And the biggest issue that I observe is that people are often managed as if back pain is a diagnosis, whereas back pain is in fact a symptom with many diagnoses underlying it. And the key message I would try and give our colleagues is that it's our responsibility as medical practitioners to make the diagnosis, hopefully a clear-cut diagnosis, and then guide the patient through the system to get that diagnosis addressed and get their pain, whatever the driver is, controlled, so that then they can restore normal movement in their lives.
And I think you like me, we're probably in the mature stages of our clinical careers have almost both had a bit of an epiphany, because our medical training, even specialist training, did not really help us conceptualize what that diagnosis was. I know for a fact myself that as a surgeon we were treating symptomatic spinal degeneration with surgical methods, at the same time not cognitively understanding what the disease was. We were treating the symptoms, as you say, with surgery, and not knowing what it was that caused those symptoms to develop. And in the last 5 years or so, I think we've really crystallized that back pain is not adequate diagnosis, even though on medico-legal reports, on insurance clinical reports, patient X has non-specific back pain. That is not good enough, and if we don't have that diagnosis, how can we possibly have a treatment?
My interpretation of the term non-specific back pain means undiagnosed back pain. I don't use that term, and I think it's intellectually lazy of the medical profession to continue using that term.
Yeah, yeah, and that is in the textbooks. You know, there are chapters in recognised, reputable textbooks about non-specific low back pain. The title of the chapter, non-specific low back pain, And without the diagnosis, the treatments are really going to be symptom-based treatments. So tell me what you think some other misconceptions there are about when patients come in and see you. You must experience, like I do, you have to go through this process of unwinding their way of thinking about their pain. Give us a bit of a experience.
One common example is that patients are often told that because they're old, they can expect to have pain, and they have arthritis, and whatever the cause of their back pain is, it seems to be commonly written off as arthritis related to aging, and therefore the patient should expect to live with it.
Feel pain. Yeah.
Feel pain and live with it and take medication for it. And I think, again, that's intellectually lazy. Yep. It's often the wrong diagnosis, and those people have a right to expect their doctors and other therapists to work harder to get a more accurate diagnosis and work harder to get a better treatment or management plan in place.
Yep, and I see the same thing a lot as well. So what do you say to someone who has back pain, they've had an MRI, and there is obvious degeneration? Often patients will read the report themselves, and the report will have typically facet arthropathy or arthritis. They'll have desiccated discs, black discs, degenerate bulging discs. These are the common words that every radiologist will use to describe the imaging. So how do you explain that to a patient to help them understand that?
What I try and do with patients first, David, is to say to them that I'm not in the business of treating their x-ray. I'm in the business of treating them based on their history and examination. So when someone comes into me with an x-ray that's been given to them, and the results have been read out and the report's been read out, and the patient has already formed a view about what is causing their pain, and it's often linked to what's reported on the x-ray, I try and say to them, well, let's put the x-ray to one side for one moment and let's go through your history, and then I'll examine you and I'll see if your symptoms and your story, your examination, so your symptoms and story fit that diagnosis, and if so, then we'll deal with it. But it may be that your story doesn't fit the report on the x-ray, and therefore we will treat what you have rather than what the x-ray says. In other words, I'll treat you, I won't treat your x-ray.
What is your most common diagnosis when someone presents to you with back pain? What do you actually write as their diagnosis?
After I've seen them? It depends on the age of the patient. Different pain conditions occur at different prevalences depending on the age of the patient. So the history, including the age, the occupational history, family history, history of accident, sporting injury, those sorts of things are all important. Generally speaking, patients fall into three large groups: people with disc problems, people with facet joint problems, and people with older people with things like spinal stenosis.
Soft tissues,
yes,
inflammation of
all
tendons
of that,
and ligaments and muscles.
all of that, yeah. So what I then try and do is I say, well, what we now need to do is work out how these conditions are impacting on your life and your ability to function in life and your ability to move, doing the things you want to do in life. And then I try and link that to controlling their symptoms, controlling their pain, so that they can overcome the movement blockade that is associated with that pain.
So what I'm gathering there, you are identifying that they have tissues that are inflamed, be it the disc, be it the facet joint, the joint capsules, the tendons, the insertions, the ligaments, the muscles. These are all potentially pain-generating structures. But as we said earlier, that is a symptom of a disease, and ultimately, would you agree that there has to be a factor that transforms these normal pain-free structures that should be pain-free, it transforms them into symptomatic painful structures?
Yes.
And I am convinced that the factor that transforms normal pain-free degeneration into painful degeneritis is movement dysfunction.
Yes.
And tell us a little bit about your experience post meeting me and your experience with functional movement therapy, which is what our audience is learning about tonight as an integral part of our practice.
I first met David when he presented to my musculoskeletal peer group at one of our clinical meetings, and listened to his ideas about functional movement and functional movement training. So I decided to go and have a look at what he was doing, and I was quite impressed by the concept and the way things were being done. So I went back. First of all, I went as a doctor to have a look, but also I then went back as a patient and actually did the program that David was offering at the time. I think it's a better way of giving patients good advice if you've actually experienced what you're recommending to them beforehand. So I went and did the program. I found it very helpful for myself, both in understanding the concepts, but also in improving my own movement patterns, because I've had problems with my lower back and lower back pain related to disc disease when I was younger. And
that's really interesting. That can bring us to a talk about prevalence. And here we've got Dr. Craig, who's a back specialist, musculoskeletal physician, and myself as a spinal surgeon, both experiencing back pain in our history, and we of all people should know how to avoid the development of back pain. And yet, we both experience back pain, and if that can happen to us, think about all the people out there that it's potentially going to affect as well. And prevalence is growing. The prevalence of the disease of movement dysfunction causing back pain symptoms is growing. It's reflective of a failure of the system to manage back pain. We're looking at stats in the order of 80 to 90% of people will experience back pain in their lifetime. At the point prevalence being 1 in 4 people. So if you have a room full of 40 people, 10 of them are going to be having back pain at that moment. The recurrence rates are around 75% in 12 months. So if you have an episode of back pain, say you're a worker, the chance that you're going to have another flare-up in that 12-month period after it settles down spontaneously is 75%. That just tells us that our whole system is geared towards fixing symptoms, not eliminating the disease. And if that was any other specialty in medicine, say heart, cardiology, or renal medicine, or any other neurosurgery, if our patients had a 75% recurrence in 12 months, that would be deemed a failure. I think
absolutely
any cardiologist who sees a patient who has a heart attack and they're going to have 75% chance of having another heart attack in 12 months, that's a failure. But yet, in the back pain industry, they're the stats that we seemingly accept. And I think it does really come down to the fact that we are not treating the disease. So, when you went through the NeuroHab program, how did you feel learning those points of performance that we did they make sense? Did they seem odd that you were learning to move differently?
No, it didn't seem odd. having been a bit of a sports tragic all my life, I've watched a lot of sport on television, and I know that a lot of the fundamental movement principles that you teach are based on the principles of Olympic weightlifting. And having watched Olympic weightlifting over the years, what I felt myself doing was setting up, in the program you offered, setting up as if I was about to lift, I was in the Olympics, but I wasn't lifting the Olympic weights.
Yeah, you were lifting the Woolies groceries.
Yes.
Yeah.
And it makes sense. It made sense to me, and when I explain it to patients now, I tell them exactly that. This is based on the principles of weightlifting, but without lifting the weights. And I teach them, or I tell them, that when they do the program, they will be exposed to or taught how to set themselves up to lift safely and efficiently.
Yeah. And how hard was it for you to transfer those movement points of performance into everyday activities? So brushing your teeth, stacking the dishwasher, picking up the TV remote off the coffee table. Did you really have to work hard at it?
I think, to be honest, it probably took me 3 or 4 weeks of doing the program to start unconsciously changing my movement patterns, and then it became automatic.
Yes. And that's a great point, is that people will continue to suffer symptoms until it becomes automatic, because if you're moving 16 hours a day, you're in bed 8 hours a day, you're moving 16 hours a day, it's really all of those movements that you do in your normal daily activities that build up that inflammation in your spinal structures. Yeah. And it's not good enough to just move well whilst you're in front of the movement therapists or in our centre. It has to translate to home, and that's why you can see why the program is 8 weeks, because you're learning a new skill. It's almost like learning how to play a violin. If you went and saw a violin teacher once or twice, you wouldn't have that new skill. But if you went and saw that violin teacher twice a week for 8 weeks, you might be able to play something on the violin. And that's what we're striving for, isn't it? So that's wonderful that you experienced that, and you conceptualize that it took you that long just to do simple, efficient points of performance.
The other thing to say, David, is that at the time I was doing the program, there were 2 or 3 of my patients who I'd referred to you, and they've all come back to me since, saying that they're much better than they were. They've got a lot less pain, and they're very positive about the program. And in that time, in the 6 months or so since I did the program, many other patients that I've referred have also come back to me and said how much better they feel as a result, and how much they enjoyed the program.
What are some of the things that you do in your clinic for patients? You've mentioned you've got a fantastic whiz-bang ultrasound machine. Tell us a little bit about that.
What I do in my practice, when I see people with various musculoskeletal pains, I try and address their pain as efficiently as possible. So I do a lot of interventional work myself. I have historically done a lot of X-ray guided, CT guided joint injections, and about 12 months ago I bought a good quality ultrasound machine, and I have a first class musculoskeletal sonographer who comes in and works with me once a fortnight, and we do ultrasound guided injections, as well as diagnostically clarifying the causes of pain in various joints, shoulders for example. Yeah. The advantage for the patient is that they're actually got the clinician who they have seen about their pain, who's actually looking at the ultrasound live and treating it based on what they see live, rather than going to an X-ray department where a sonographer does the ultrasound and the non-clinical radiologist reads the films afterwards and writes a report, and then the patient goes back to the original clinician, me, to discuss the report. So it's much more efficient in terms of time and cost for the patient to do things that way. So
I'd like to use that point to bring us to the discussion about movement obstructing barriers. And so I think what you've highlighted there is that your ultrasound guided, very specific and precise, high utility injections are alleviating active nociception or active pain generators, and that is behaving as a movement obstructing barrier.
Yes.
Once that inflammation is addressed, if that's the end of the story, if the patient goes home and never comes back and sees you without engaging in motor pattern retraining or movement therapy, we can be almost 99%, 100% sure that that structure that you just injected will become re-inflamed, because that is the time then to say, okay, I've alleviated a symptom, a movement obstructing barrier, and now we want to address through movement therapy the corrupted movement that made that structure inflamed in the first place.
Yes.
And I think that's what I refer to that as a tandem approach. We address symptoms accurately with good diagnosis, good clinical acumen, and then we address the movement dysfunction which drove the structure to become inflamed in the first place. And is that now your algorithm, that you address symptoms and then address disease with movement therapy?
Absolutely.
That makes sense. Lots logical.
And certainly, you see it a lot with the lower limbs. You know, people with back pain are often, their back pain is the result of problems in their hips or their knees. Their movement patterns are corrupted by, for example, an osteoarthritic knee or an osteoarthritic hip, and they load up that limb differently because of the pain in that limb, and then that has a flow-on effect to the lower back, and they develop low back pain. So you need to treat the whole patient and address all of the pain problems in the patient, and then work on their, as you say, their corrupted movement to try and get restore them to normal movement.
Because patients will automatically try to maladapt or compensate for their deficiencies. It's a little bit like going on a bushwalk with a stone in your shoe, and if you don't stop and take the stone out, you're going to start walking a little bit differently to alleviate that discomfort. And after a little while, if you walk on the outside of your foot because the stone's on the inside of your foot, you're going to start to get a sore ankle. And so I do the same. I perceive myself in a similar way as a surgeon. I no longer see myself as a surgeon that fixes back pain. I see myself as a surgeon that eliminates surgical movement obstructing barriers in order to give the patient the potential to regain their movement proficiency. And it's regaining the movement proficiency that allows the back pain to then disappear. If I don't do the surgery, then the patient cannot engage in movement therapy. If someone has a terribly inflamed enthesitis or a bursa or a terribly inflamed facet joint, they can't engage in movement therapy. And so that's where Mark comes in, and he goes, all right, well, we've identified this as an actively inflamed joint. We'll put that little fire out, and then we engage in movement therapy, and the fire doesn't restart. And so we therefore are movement obstructing barrier clinicians.
Yep.
That's a really important point,
Which
is not taught to us. We're made to think that we treat back pain, and we don't. We should be thinking that, no, we are MOB, movement obstructing barrier clinicians.
Absolutely. And my role is the medical side, yours is the surgical side, and together it seems to work rather well.
Well, I think we've covered a lot of ground there about back pain, and hopefully our audience will gain a lot from that, and it'll reinforce some of the themes and messages that we're trying to get out there. I perceive what we're doing is really as a paradigm shift, and I've used that term in some of my presentations. At first, it doesn't necessarily sit well with a lot of people, because It's almost like pointing the finger at people's lifelong careers potentially being suboptimal. But you know, you've got to look at the science, and you've got to look at the numbers. And I think we are really implementing a paradigm shift, and the more our clinicians and general practitioners understand the imperatives, the more we can start to make some gains into this disease, which is a huge economic burden on our country. I think some of the numbers, depending on how you crunch the numbers, we're talking about $50 billion a year, on par with diabetes and cardiovascular disease. Certainly not obtaining the same profile as diabetes and heart disease, because people don't die from it. People just sit at home and suffer and are made to feel like malingerers. So it doesn't receive the same profile, but certainly economically it's contributing to us paying 50% tax to look after people. Say, for instance, a young worker, 25, you know, some trivial back injury and never working again. That's almost $1 million every 5 years to support that fellow on disability support and pension, excluding the suffering that poor guy has to go through.
My focus is always is on the individual, and my experience has been, if you can change someone's chronic pain, if you can lessen someone's chronic pain, or better still eliminate it, you change their life. And when that happens, it's incredibly gratifying as a practitioner, and incredibly satisfying for the patient. And I think you're on something really, you're doing something very important, and you're onto something really big here, David, so keep it up.
All right. Thank you very much. Thanks for watching.
My pleasure.
Thanks, mate.
Okay.